Alright guys, this is Dr. Manish, your ophthalmology educator. Now in this video we are going to discuss NEET PG 2025 questions and the total questions which were there in the ophthalmology segment were nearly 9, right? Of course, there are one or two overlapping questions which I have put up in the end, but there are 7 hardcore MCQs in direct relation with ophthalmology. And those two questions you may consider them in association with some other subject like radiology, maybe dermatology, or maybe medicine. But yes, I'm going to do it in the end, and I am very happy to share that all these 9 questions were discussed in the video lectures which I had put up on my brand new startup, that is EyeCoach app. So the vision while building EyeCoach app was to make this app one-stop resource for ophthalmology. So in that app you are going to find regular NEET PG INICET target lectures, regular FMGE lectures. There are revision courses like one last revision, IQ booster. There is a PYQ discussion as well. There is test and discussion videos as well, in which 75 MCQs test is there, after which there is a discussion which is around 9-10 hours. And also this app is not only meant for UGs, but we have recently launched a course for our dear residents and practicing doctors by the name of OphthoEdge, where not only myself, in association with 3 more ophthalmology faculties who are expert in this field, they are teaching the residents. So for resident course we are 4 faculties which are taking lectures, and we are constantly updating our OphthoEdge resident training master course. And thank you for your feedbacks. I have been receiving very good feedbacks from all of you guys. Please keep on letting us know how you are finding this new app. This app is available both on iOS and Android, and the name of the app is EyeCoach app. And the idea of this app is to help you reach from basics to brilliance. And yes, I would love to have your feedbacks. Do download this app, and we are daily posting 10 MCQ tests on different subjects. So in the test of the day section you will find different tests, 10 MCQs test which is to be done in 20 minutes. And once it is done, so you will get your total score in the end, right? So it is very important to practice MCQs on daily basis. We understand that you are doing one subject on one day, but we don't want to, we don't want you to miss upon the other subject. So daily we are posting 10 MCQs under test of the day tile. Just check that out, and you just make it a kind of a religion that you have to appear in that test of the day on daily basis to to practice, to solve new MCQs every day. And also there is a tile which is free resources tile. That free resources tile has instruments PDF you are going to get. That's free of cost. You just launch the app, click on free resources tile, and you will see 50 instruments PDF in which the identification, the use of that instrument is mentioned along with the pic. And you will also find some demo lectures. Do watch those demo lectures, and you will have an idea what work we are doing. And yes, all my lectures are based on the real patient videos, so that to give you a feeling of sitting with me in my OPD. I'll also take you to my minor OT, main OT. Will be doing a lot of general procedures. Okay, so with this, let's start discussing the NEET PG 2025 MCQs one by one. And I always request you guys to mark the answer by eliminating the options one by one. Don't simply try to jump upon the answer. It reduces your tendency to pick up the incorrect option. Yes, okay. Now, first question, an elderly patient presents with white dandruff-like deposits on the anterior lens surface seen during slit lamp examination. What is the most likely diagnosis? Now, if you don't have any idea, there are high chances that you will see, okay, this is white thing which is present at the periphery. You will have a tendency to think that this is a cortical cataract. No, it is not a cortical cataract. Thankfully, it was not in the option. Otherwise, some students have a tendency to pick up cortical cataract. ये मैं अपनी classes में भी बोलता हूँ. Don't confuse pseudoexfoliation with that of cortical cataract. Okay, so there is dandruff-like deposits which are present on the anterior lens capsule. This dandruff-like deposit is also present on the epithelium of conjunctiva. Usually in pseudoexfoliation, it can also be present on the zonules, ciliary body epithelium, and iris. Right? Okay. So this is of course pseudoexfoliation, but let's eliminate the option one by one. So one is pigment dispersion syndrome. As the name suggests, Shakespeare क्या बोल के गया? नाम में क्या रखा है? डॉक्टर मनीष क्या बोलते हैं? नाम में ही सब कुछ रखा है. Pigment dispersion syndrome. Do you see any pigment in this image? No, you don't. Pigment dispersion syndrome is when the configuration of the iris, normally iris configuration is convex anteriorly, but in some patients it become concave anteriorly. So when the pupil dilate constrict, when it is concave anteriorly, it is going to be convex posteriorly. The convex part of the iris is going to rub over the lens and its zonules, and you know the posterior layer of the iris is posterior pigment epithelium. So there is pigment dispersion in the anterior chamber which will get settled in the trabecular meshwork, which will clog the trabecular meshwork, and it will stall the flow of aqueous humor from the anterior chamber into canal of Schlemm via trabecular meshwork, which will raise the intraocular pressure. And that is why in concave iris configuration there is raised intraocular pressure, which ultimately leads to pigment glaucoma. समझ पा रहे हैं? लेकिन pigment dispersion syndrome में you see pigments in the anterior chamber. अब यही पिगमेंट अगर कॉर्नियल एपिथेलियम के पीछे नजर आए, because there is pigment which is there in the anterior chamber, it will get stuck at the back of the cornea. You call it as Krukenberg syndrome. Krukenberg spindle. देखो ये हम क्यों डिस्कस कर रहे हैं? Because my idea is not only to tell you the answers, but also when you are appearing for your NEET PG 2026 exam or maybe INICET November 2025 exam, you should know something about the related topics. है ना? This will also be helpful for your juniors who are currently doing their internship, maybe in the final year or third year, so that they understand how to solve such questions and what are the important points in relation to the options which are there. So Krukenberg spindle, this is your one PYQ. Second PYQ is Sampolizi line. What is Sampolizi line, boys and girls? Sampolizi line is again pigment dispersion in the trabecular meshwork leads to highly pigmented trabecular meshwork. उसको हम Sampolizi line बोलेंगे. तो pigment dispersion syndrome is eliminated. You don't see any pigment in the anterior chamber. Okay. Persistent pupillary membrane, ये देखिए persistent pupillary membrane की मैंने यहाँ image लगा दी है. तो what happens is during embryological development of the eyeball, so basically lens is supplied by anterior pupillary membrane, then there is capsulopupillary membrane, and there is posterior pupillary membrane. This is nothing but the blood supply, anterior pupillary portion, capsulopupillary portion, and posterior pupillary portion. If there is remnants of this anterior pupillary portion of the blood supply, which blood supply? There is hyaloid artery which is coming and supplying the developing lens. If there is anterior pupillary portion which fails to get resorbed, there is persistent pupillary membrane. So it looks like this. Is it looking something like this? No, that is also eliminated. And iris cyst is development of small nodule or cysts on the surface of the iris. You cannot see that, boys and girls. So the answer is pseudoexfoliation syndrome. Otherwise, you know, based on the history, dandruff-like material deposits on the anterior lens capsule, so slit lamp image is given, so you know it is pseudoexfoliation syndrome. Okay, चलो आगे चलते हैं. मैंने आपको एक चीज और बताई थी, देयर इज कनकेव एंटीरियर कॉन्फिगरेशन, देयर इज कॉन्वेक्स पोस्टीरियर. सो व्हेन देयर इज कांस्टेंट रबिंग, देयर इज रिमूवल ऑफ द पिगमेंट एंड इट लीड्स टू trans illumination defect. So when the light enters through the center, it will come out from the periphery where there is removal of the pigment due to constant rubbing of the iris on the anterior lens capsule and the zonules. So trans illumination defect is present in pigment dispersion syndrome. याद रखिएगा. Okay, all right, coming on to the next question. Which condition is treated using an intact ring? What is intact? That is intrastromal corneal segment. So these are semicircular rings like this. ऐसी rings होती हैं. Okay, they are made up of polymethyl methacrylate. So what happens is, if the patient is having keratoconus, so can you tell me which is the treatment of choice for keratoconus? It is C3R. C3R is corneal collagen cross linking with riboflavin. अभी समझाता हूं आपको ये होता क्या है. ठीक है, ये देखो C3R बन गया ना हमारा. Okay, now what happens is, when there is keratoconus, so first thing that you can go on for is to give rigid gas permeable contact lenses. They are made up of CAB, cellulose acetyl butyrate. Since they are hard, they push back the cone of keratoconus. This is done in early keratoconus. Okay, but if the keratoconus is constantly progressing, then you go on for C3R. So you debride the superficial layer of the cornea, expose the corneal stromal bed, you put riboflavin. Riboflavin is a photosensitizer. So it is going to photosensitize the stromal region, and then you expose the stroma with that of UV rays. So UV rays is going to cause corneal collagen cross-linking, which will cause stretching of the cornea. When there is stretching of the cornea, so there is cone of keratoconus which will go down. So that is your C3R. This is treatment of choice, but you can always go or for plan B, plan C if plan A is not available. That is your intact. Intact is you put half moon-shaped or semicircular PMMA rings at the periphery. So because you are placing it at the periphery by giving an incision, so this is the cornea, you will give incision and you will place the semicircular PMMA intacts at the periphery. They are going to pull the cornea at the periphery such that the cone of the keratoconus will go down. So that is the role of intacts. But let's eliminate the options one by one. We know that this is intacts. Can you appreciate the semicircular rings? Okay, so answer is of course keratoconus, but we want to eliminate the option glaucoma. So why in glaucoma you are going to put something in the cornea? Not possible, na? Not a valid image based on if we are thinking of glaucoma, hai na? Corneal ulcer. If there is corneal ulcer, you will see some opacity on the cornea. You will see some inflammation in the cornea. Maybe some debridement of the superficial layers of the cornea, or maybe some epithelial defect, but you don't see that. The cornea is very clear, so corneal ulcer is eliminated. If we are talking of cataract, there is nothing in the lens of this patient. Can you appreciate something here? It appears normal na, so why you want to choose cataract as an answer? So the answer was pretty straightforward. It is keratoconus. Okay, all right. Now a 15-year-old female presents with a painless, gradually increasing mass located lateral to the lateral canthus. So canthus is the region where upper and lower eyelid they meet. So medial canthus, lateral canthus. Okay, present for past 10 years, age is 15 years, that means it is present since 5 years of age. Okay, on examination the mass is non-tender and slowly progressive. What is the most likely diagnosis? So there was an image which was asked. Okay, this was the image. Okay, can you appreciate that there is some mass? Okay, now coming over to the options, even if you don't know anything, still you can mark the answer. First thing, we had discussed this in OLR as well. Of course, in regular videos, I have told you that if there has to be capillary hemangioma, first and foremost, it is most common benign intraorbital tumor of adults. समझ पा रहे हो? But the age is 5 years, so that is eliminated. And of course, capillary hemangioma. Okay, all right, so this can be eliminated here because it is present since last 10 years and the age is 15 years, so we are talking of children. Okay, lacrimal gland tumor, if there has to be lacrimal gland tumor, can you tell me the most common lacrimal gland tumor overall? Is pleomorphic adenoma, है ना? Pleomorphic adenoma is there, and this is your benign. This also we had done. And most common malignant is adenosystic carcinoma. Okay, this is malignant. अगर पूछा जाए which is the most common benign lacrimal gland tumor, go for pleomorphic adenoma. अगर पूछा जाए which is the most common overall lacrimal gland tumor, again pleomorphic adenoma, because overall benign is more common than malignant. अगर specifically malignant पूछा जाए तो adenosystic carcinoma, है ना? And lacrimal gland tumor, if it is, because you know the position of the lacrimal gland is superotemporally, right? If there is lacrimal gland tumor, it is going to push the eyeball inferonasally. So there is typically inferonasally proptosis, non-axial proptosis will be there. Of course, there can be associated ptosis. Ptosis can be seen in dermoid as well. Dermoid cyst, ptosis can be there. Okay, ptosis हो सकता है. समझ पा रहे हैं? Okay, and now if I am talking of lacrimal gland tumor, it has to be present somewhere here, because that is the right anatomical position of the lacrimal gland, not here. It is away from the lateral canthus and slightly superiorly, but the position of the lacrimal gland is here. Based on this, you can easily identify. Okay, now the answer is dermoid cyst. Now this dermoid cyst can also lead to some sort of proptosis in some cases, but lacrimal gland tumor, there are high chances of proptosis, but here you can see that there is no proptosis. Okay, all right. And fourth option is osteoma, which is a vague option, right? So we can eliminate this. Lacrimal gland tumor is also eliminated, so we are left with dermoid cyst. And also to mention that lacrimal gland tumor is more common in adults, but here we are talking of a 5-year-old child because age is 15 years and it is present since last 10 years. Okay, so that is also eliminated. Even if you don't know much about, you know, superotemporal anatomical position of the lacrimal gland, inferonasal proptosis, still based on the age, you can easily go on for marking dermoid cyst, because that is the most common benign intraorbital tumor of childhood. We have done it multiple times. Okay, a patient presents with guttate lesions in one eye and bullous keratopathy in other eye. Okay, we are talking of guttate lesion. What is the most likely diagnosis? So don't get confused. So what happens is, if there is damage to the endothelium, what is the function of endothelium, boys and girls? See, this question was kind of integrated with that of the anatomy, although we had done this. But even if you are not aware of this disease, so if you know the anatomy of cornea, you'll be able to tell the answer. So the function of endothelium is to maintain the cornea in dry state, है ना? How it maintains the cornea in dry state? By having sodium potassium pumps which throw 3 sodium in the anterior chamber, take 2 potassium inside the stroma. Yes, so water follows that sodium and the cornea is maintained in the dry state. If there is damage to this endothelium of the cornea, the water will enter into the cornea. It will cause corneal edema, and it can also lead to development of the bullae over the corneal epithelium. You call it as bullous keratopathy. Number 1. Second, if there is damage to the endothelium, so what happens is there is formation of excrescences. There is formation of excrescences which gets deposited on the Descemet's membrane of the cornea. This excrescences is secreted by the dying endothelium cells. Okay, now why the endothelium cells are dying? Because of one disease, dystrophic disease of the cornea, that is Fuchs endothelial dystrophy. Okay, now based on the different options, let's eliminate them. So CMV is cytomegalovirus. So in cytomegalovirus infection, can you see cornea guttata or bullous keratopathy? CMV retinitis is common, leading to sauce and cheese appearance of the retina, but not that of cornea. What is HSV keratitis? If there is herpes simplex virus keratitis, there must have been some mention of dendrites or maybe endotheliitis, disciform keratitis, geographic keratitis, है ना? But there is no such mention, है ना? So that is eliminated. What is interstitial keratitis? Interstitial keratitis when there is inflammation of the stroma, without any epithelial defect. This interstitial keratitis typically seen in TB, syphilis, leprosy. And this interstitial keratitis may also be seen in conditions like CMV. If there is CMV infection, it can lead to interstitial keratitis, although very, very rarely. But the common causes are TB, syphilis, leprosy. Okay. All right. So eliminating these options, we are left with Fuchs endothelial dystrophy. Now, binocular single vision consists of the following components, है ना? Based on the 2 images which were given, can you identify which image depicts what? So first and foremost, BSV consists of 3 grades. First grade says that you should have simultaneous macular perception in order to have binocular single vision. Binocular single vision का मतलब है मैं दोनों आंखों से एक ऑब्जेक्ट को देख पा रहा हूँ, है ना? Now there are different grades, grade 1, grade 2 and grade 3. Grade 1 is simultaneous macular perception. इसका मतलब to be able to have binocular single vision, एक समय पे दोनों आंखों के जो मैक्यूला है, the macula of both the eyes should be stimulated at the same time. Second is fusion. Now the image perceived by the right eye and the image perceived by the left eye, these 2 images should be fused in order to have a single vision, which is very obvious. Third is stereopsis. Now if I'm seeing towards the camera, right eye the angle is different, left eye the angle is different, so I am seeing towards the camera with my both the eyes with different angles. So when both the images are superimposed, I will have a perception of depth. I will have stereopsis means three-dimensional view I'll be having. So that is the third grade of binocular single vision. So there were two images. Now first is, check this out. So let's take this as first in discussion. Okay, so this is your image 1, this is your image 2. So let's first discuss second image. So in case the image of a hut is placed in front of the left eye and image of a dog is placed in front of the right eye, this you call as simultaneous macular perception. समझ में आ गया है ना? तो ऐसा लगेगा जैसे a dog is in the hut. Yes, so that is depicting simultaneous macular perception. But if a image of rabbit, a card of rabbit is placed in front of the left eye, which is not having anything in its hand, but in front of the right eye a card is placed in which the rabbit is holding a flower. So due to superimposition of the left image with that of the right image, the patient is going to see a single rabbit with a flower in the hand. It is because of the act of fusion. Have you understood this? Now they have asked, what are these two images depicting? Now you have got an idea. So A is, image 1 is of simultaneous macular perception and image 2 is of stereopsis. Okay, no, eliminated. Second is, image 1 is of fusion, image 2 is of simultaneous macular perception, right? Image 1 of simultaneous macular perception, 2 is of fusion. No, it's ulta. Image 1 of fusion and 2 is of stereopsis. No, not at all. So the answer is B. Image 1 is of fusion and 2 is of simultaneous macular perception. समझ में आ गया? Okay. Now coming over to the next question. Which of the following is true about orbital cellulitis? This is in the first 30 minutes of my lecture on orbit. I always reinforce to do orbital cellulitis, one of the most important diseases in ophthalmology, है ना? Now, which is true about orbital cellulitis? Inflammation is limited to anterior orbital septum. अब देखो, I have put up an image. So this is your orbital septum. So orbital septum. So if there is any inflammation which is anterior to the orbital septum, it has to be there. You will call it as preseptal cellulitis. But if there is any inflammation posterior to the orbital septum, which will be here, you call it as septal or postseptal, or even better, you call it as orbital cellulitis. Now, if there is inflammation posterior to the orbital septum, so it is forming a closed chamber behind it. Because it is a closed chamber and there is inflammation, the intraorbital pressure will start getting built up and will compress all the structures which are present inside that of the orbit. What are those structures? Optic nerve, oculomotor nerve, all the nerves, all the structures which are passing through superior orbital fissure, optic canal, inferior orbital fissure, isn't it? So what passes through the superior part of superior orbital fissure? Lacrimal nerve, frontal nerve, trochlear nerve. Trochlear nerve supplies superior oblique, है ना? What are the structures which are passing through the middle part of superior orbital fissure? Nasociliary nerve, oculomotor nerve, superior division, inferior division, abducent nerve. What are the structures passing through the inferior part of superior orbital fissure? It is the exit of inferior ophthalmic vein. From the superior part, there is exit of superior ophthalmic vein. There is also exit of recurrent branch of middle meningeal artery, which is recurrent branch of middle meningeal, recurrent branch of ophthalmic artery, है ना? So now please understand, if there is raised intraorbital pressure, it is going to compress all these structures. Through optic canal, there is optic nerve. So optic nerve is compressed, loss of vision. Oculomotor nerve is compressed, extraocular muscle movement restriction. Abducent nerve compressed, there is lateral rectus palsy. Trochlear nerve compressed, superior oblique palsy. And there is also pupillary reflex, which will not be present because pupillary reflex has got afferent via optic nerve, which is compressed, efferent via oculomotor nerve, which is also compressed. Now, having understood this simple concept, let's move over to the options. I am sure that you will be able to now answer the question. Inflammation is limited to the anterior orbital septum. No, it is posterior to the orbital septum. Okay. Topical antibiotics are given. Mind you, the most common organism associated with orbital cellulitis is Staph aureus. Now, the drug which is effective against Staph aureus is I always say IV vancomycin. Of course, you can top it up with third generation cephalosporin, but single drug of choice is your vancomycin because the coagulase negative Staph aureus is resistant against penicillin. So you go on for vancomycin. Okay, so you will give intravenous, you will not go for topical antibiotics. So that is also eliminated. Clinical feature include proptosis, yes, because raised intraorbital pressure. Orbital swelling, yes, periorbital swelling is there. Normal pupil and with extraocular movements, no, the pupil will not be reacting to light. We just understood that. And extraocular muscle movements will be affected. Hai na? So that is also eliminated. Now, ethmoid sinusitis is the most common cause among all age groups. Now, I had put up a screenshot from Parsons in my Telegram group, Ophthalmology by Dr. Manish Chhabra, in which it is clearly written that the most common cause of orbital cellulitis is association with bacterial ethmoid sinusitis. It is written. If you want to check that out, you can go to Telegram group and search for my screenshot from Parsons. So that is a clear-cut answer here. है ना? Okay. Chalo, let's move over to the next question. A 15-year-old tall boy comes to the OPD. Okay. Examination revealed high arched palate, joint hypermobility, long fingers and toes. By this time, you know what we are talking of. On ocular examination, bilateral ectopia lentis. And in this particular disease, there is typical superotemporal subluxation of the lens. Okay. Which gene is most likely affected in this inherited disorder? Okay. Now, COL5A is associated with Ehlers-Danlos syndrome. Is it Ehlers-Danlos syndrome? No. PAX6 associated with aniridia. This aniridia may even lead to formation of primary open angle glaucoma. Mind you, when we say PAX6 associated with aniridia, aniridia does not mean that there is absence of iris. Iris is there, but that iris is rudimentary. This aniridia is a misnomer. Always remember this. And TGFB2 is associated with persistent hyperplastic primary vitreous, PHPV. Yes. Okay. But we are thinking of which disease? We are thinking of Marfan syndrome, and for Marfan syndrome, it is the fibrillin gene which is associated. Hence, this is the answer. Okay, and you can appreciate that these are your zonules. Just the image to depict. So there is superotemporal. If this is your right eye is this, है ना? तो ये कहाँ जा रही है? Superotemporal subluxation. Superotemporal. And how will you remember why it is superotemporal? M for Marfan's. So it is superotemporal, and H for homocystinemia. So H is inferonasal subluxation. Remember this. Inferonasal subluxation of lens, which is in homocystinemia or homocystinuria. अगर homocystinemia होगा तो यूरिया अपने आप हो जाएगा ना. Okay. Now, a 24-year-old man with progressive low back pain for 1 year, morning stiffness and past anterior uveitis. क्योंकि यहाँ पे anterior uveitis हुआ तो एकदम से मेरे eyebrows ऊपर को हो गए. अरे आंख की बात हो रही है, तो चलो इसको भी डिस्कस कर लेते हैं. एंड sacroiliac joint x-ray is normal. Best test for early diagnosis. Now, if you know that there is association of one kind of arthritis with anterior uveitis, you can easily integrate it with the radiological investigation. Now, if we are talking of rheumatoid arthritis, rheumatoid arthritis can be associated with anterior uveitis. I have specifically told you that rheumatoid arthritis is not associated with anterior uveitis. It is actually juvenile rheumatoid arthritis which is associated with anterior uveitis. So you will eliminate the investigation which is done to diagnose rheumatic arthritis. So anti-CCP bodies is eliminated. But which arthritis can be associated? Remember, PAIR. P is psoriasis, A for ankylosing spondylitis, I for inflammatory bowel disease, R for reactive arthritis or Retter's disease. Yes, so these four can cause anterior uveitis, but they are talking of low back pain and sacroiliac joint x-ray is normal. There is no mention of any psoriatic lesions. There is no mention of any ulcerative colitis or Crohn's disease features. There is no mention of Retter's disease, because Retter's disease has reactive arthritis, and Retter's disease is also associated with urethritis, conjunctivitis. There is no such association. So we will think of ankylosing spondylitis. अब जल्दी से बता दो ankylosing spondylitis में हम earliest diagnosis के लिए क्या करवाएंगे? X-ray is normal. We will go for MRI of sacroiliac joint because it will show edema. It will show edema, MRI. So MRI is used to detect the early ankylosing spondylitis, and ankylosing spondylitis is more common in young males, young progressive low back pain. Okay, so there is marrow edema, but here you know the answer is C. Okay, now there was one more question. A young adult with facial pain and vesicular lesions in or around, some said around the mouth or some said in the mouth. Okay, so what can be the cause of pain in this patient? So I'm sure that you must have heard something of trigeminal neuralgia, है ना? So it is usually associated with herpes simplex virus. Because if you could recall, you know na that herpes simplex virus or herpes zoster ophthalmicus, whenever there is infection, they will become resident of ganglion of trigeminal nerve. The name of that ganglion is Gasserian ganglion. And if we talk about trigeminal nerve has got three branches: ophthalmic division, maxillary division, and mandibular division. Now ophthalmic division give rise to nasociliary nerve. Okay, nasociliary nerve give rise to long posterior ciliary nerve. Long posterior ciliary nerve supplies the cornea. That is why even in herpes simplex virus keratitis there is absence of blink reflex, because there is defect in the afferent pathway. Because when you will take a cotton wisp, touch it on the corneal surface, because of the involvement of the nerves, there is no reflex which is there, because there is no impulse which is reaching. There is absence of afferent impulse. Yes, so that is why there is blink reflex which is absent. So the history: facial pain and vesicular lesions in or around the mouth. Okay, so we are going in favor of herpes simplex virus. So what can be the cause of pain? So probably it can be associated with the involvement of trigeminal nerve, which is leading to facial pain, and the answer is C, which is herpes simplex virus. Okay, so all right, so these were the questions. So 9 by 9 question we have discussed all these topics in our video lectures, and I hope that you enjoyed the session. Any doubts, any queries, you can reach out to me directly on my WhatsApp, and that is 9814111330. And in case there were more questions, you can bring those questions to my notice, and I'll be happy to get back to you with the best possible answers. and do give me your feedbacks and let me know how you like the discussion. Best wishes from my side.